This will be the last video in the series for cardiac arrest management. We left off talking about time frames for medication administration, specifically for epinephrine every 3 to 5 minutes and defibrillation being every 2 minutes. And we said that if you give medication every other rhythm check, then you're going to be giving it every 4 minutes, which obviously would fall in between your 3 to 5 minute mark. So that's the easiest way to keep track of when you give what and when you do what intervention. Because otherwise you have two different time frames to keep up with, and it's going to be very difficult when you already have a whole lot going on in your mind trying to keep straight while you're working this call. All right. So let's continue down. We are giving epi, we're defibbing every 2 minutes. There are a couple of drugs which are commonly given in the pre-hospital setting for pulseless VTAC and VFib. You already have been exposed to both for the treatment of VTAC with a pulse, but our dosing is going to be a little bit different for cardiac arrest. Amiodarone is the first drug. Amiodarone, if you remember, is a class 3 antiarrhythmic. It works by blocking primarily potassium channels, but does block some sodium channels as well. It exerts its primary effect on phase 3 of the cardiac cycle and prolongs phase 3, thereby prolonging the effective refractory period. So in cardiac arrest, it works a little bit different, or the purpose in its administration is a little bit different with VFib at least than it would be for VTAC with a pulse. We can break that down more later. Right now, we're just going to focus on what it is. So amiodarone, our dose is 300 milligrams IV push. So this is not a drip. We're not mixing this in a bag and giving it over 10 minutes like we do for VTAC with the pulse. We're giving 300 milligrams IV push it in the IV. Everything that we give, most everything that we give in cardiac arrest is going to be IV push. Okay? We oftentimes give a lot higher doses in cardiac arrest and more potent concentrations, your epi 1 to 10, for example. The reason for that is because in cardiac arrest, I'm only circulating about 30, maybe 40% at the most of the blood that the body normally circulates when I'm doing really, really good chest compressions. So because of that, I have to have more medicine in the body in order to have the same effect. So our dose is 300 milligrams IVP, or IO, for amiodarone. And I can give this at the same time that I give my epinephrine. Okay, I don't give epi one rhythm check and then amiodarone the next, or epi one medication time and then amiodarone the next. If you do that, if you give it in alternating like that, then you can end up with epinephrine every 10 minutes, right? Or really, I guess every 8 minutes instead of that 3 to 5 minute mark. So epi every 3 to 5 minutes. You can add in your amiodarone. You don't have to do a full cycle of CPR. You don't have to have already given one epi. You don't have to have worked a code for a certain amount of time. You don't have to have already provided a certain number of defibrillations. All of those things are myths that you'll hear people say. You can go ahead right out the door if you know you're working a ventricular rhythm. The first epi you give, you can also give amiodarone if you know it's a ventricular rhythm. Okay, same thing with any of these medications. So amiodarone 300 milligrams, that is your first dose. After 3 to 5 minutes, okay, so the next medication administration time, I'm also going to give my epi 1 milligram. I can repeat my amiodarone dose, but it's going to be half the actual dosage, so it's 150. So I can give epi and amiodarone together, 1 milligram of epi, 300 milligrams of amiodarone. Then on the next rhythm check, I don't give any medications because that's just 2 minutes, right? The following rhythm check, which means I'm at 4 minutes from when I gave my initial medications, I can give another milligram of epinephrine, 1 to 10,000 concentration, and then 150 milligrams of amiodarone IV push. That is all the amiodarone that I can give. Okay, I only give it twice, 300 and then 150. The other drug that I can consider giving is lidocaine. We don't typically give both. You normally pick one or the other. Okay, one or the other. The way your protocol has this termed is a little misleading because it seems to say that if the rhythm is refractory to your amiodarone, then you can consider lidocaine. And I'll try to verify that. That's new in the protocol. I don't recall seeing that before. In the hospital, they do sometimes give both, but normally we're sticking with one or the other. So if it's amiodarone you're doing, it's 300 and then 150. If it's lidocaine, then our dose is 1 to 1.5 mg per kg. And we're also going to do this the same as we would with amiodarone. We're going to do it with our epinephrine. So 1 to 1.5 mg per kg. It's IVIO. Our follow-up dose is 0.75 mg per kg. And I could theoretically repeat that one more time, right? If I gave 1 mg per kg and then 0.75, I gave 1.5 mg per kg, then I gave 0.75 mg per kg. I could give 0.75 mg per kg one more time because my max dose is 3 mg per kg. All right. So, but that's every 3 to 5 minutes. The other thing that I may consider, and this is going to be more specific to a patient with torsades, and torsades, I may think about this earlier, but magnesium sulfate. Magnesium sulfate is a drug we talked about last week with bronchial constriction, and I said that there's a lot of uses for magnesium sulfate. We'll talk about it again during pregnancy. We've already talked about it for OB. We'll talk about it for some seizures. We'll talk about it now for ventricular arrhythmias and cardiac arrest. We've already talked about it for perfusing arrhythmias with multifocal ventricular tachycardia. So now we're looking at VTAC, VFib without a pulse. We've already treated this patient. Nothing we're doing is working. We can consider giving magnesium sulfate 2 grams IVIO. The only contrary to that would be if the patient is in torsades, you can go ahead and hang this. All right. But this again is an IV push. Magnesium sulfate 2 grams IVIO. Since we're in cardiac arrest, it's an IV push, not a drip. All right. So a newer thing in the protocol is called dual sequential defibrillation. Dual sequential defibrillation. And this entails defibrillating the patient with 2 separate cardiac monitors, and they're one right after the other. So the first monitor, I put the pads in the normal place, one on the upper right anterior chest and one on the, a midline, probably 5th ICS area on the left side. And then the other pads, if you have room, are going to go front and back. The other option would be the complete opposite. So up on the upper left-hand chest and down on the right-hand bottom side of the chest here. There's a couple of different configurations for that. Follow your local protocol for which placement your particular agency is wanting you to use. But we can consider this intervention after 5 unsuccessful defibrillations. We've been working this code. We've defibrillated at least 5 times, so we're working a ventricular rhythm that will not convert for whatever reason. I've given antiarrhythmics, I'm giving epi, I'm doing CPR, I've defibrillated 5 times, and I'm not getting what I'm looking for. It's not working. Patient's still in a ventricular rhythm, be it VTAC or VFib. Now we do sequential, dual sequential. So I've got 2 monitors hooked up to the patient. I'm going to trial both of them up to full adult dose, whether that's 150 per your manufacturer's recommendations or 200 if your manufacturer doesn't have a recommendation. And this is not synchronized. This is sequential. So there's a difference in those 2 words, synchronized versus sequential. Synchronized means at the same time, right? So that would mean we say 1, 2, 3, shock. We push the button at the same time. That's not what we want to do because we're giving 300, 400 joules to the patient's heart all at the same time, and that's just enough to make it a good medium rare, all right? So that's not what we're looking for. Instead, we want to shock, shock. So sequential. So 1, 2, 3, shock, shock, one right after the other. And the goal here is to fully depolarize the cardiac tissue with hopes that it will respond in a normal pattern and the SA node can kind of take over as the pacemaker again. I've only actually done this particular procedure one time, and the one time that I did it, it worked like a charm. We'd been working a code on this patient for, probably half of an hour, and she had just stayed in a ventricular rhythm. We did dual sequential one time, and she converted to a sinus rhythm and regained a pulse. So it does work. I don't know what the statistics are on it per se, but the one time I've done it, it worked well. Your pearls are exactly the same as they're not exactly the same. They're very close to the same as the other protocols. There's a couple of extra little things down here at the bottom, so let's take a look at this. All right, so avoid procainamide and CHF or prolonged QT. You'll notice that procainamide wasn't even up here, right? It says amiodarone, lidocaine, and then MAG. That's because your agency, whoever you're working for, has the option to add in medications. Okay, this is just a general protocol for the state of North Carolina. Your agency can add things in. All right, so avoid procainamide in congestive heart failure or prolonged QT syndrome. Patients with a prolonged QT interval. Magnesium sulfate is not routinely recommended during cardiac arrest, but may help with torsades de pointes, hypomagnesemia, and suspected DIGE toxicity. So DIGE, digitalis, that is a drug that people take It was originally for congestive heart failure. It is now used for CHF still, sometimes for hypertension and sometimes as an antiarrhythmic. But normally your congestive heart failure patients are who you're going to find taking DIG. It's not a commonly prescribed medication anymore, and it's got a fairly narrow therapeutic window, and that is why. We just have medicines that work better than it does now. If you ever see a test question that asks which of the following medications are derived from a plant source, the answer is probably going to be digitalis, and it is derived from the foxglove plant. Just some random knowledge for you there. So, if no IV or IO, drugs that can be given down the ET tube, we should be given down the ET tube. Now, that being said, unless your patient is a multi-system trauma patient and their both upper arms and both upper legs are broken, and you don't carry sternal IOs and can't drill the iliac crest, which would be very few patients, then you should have no reason to give drugs down the tube. Okay, this is not something that we do very much anymore. It was fairly common before IOs in the field, which have been around maybe since 2010, 2011 in most places. Excuse me. But in general, we don't give drugs down the tube. If, for some reason, you can't get an IV and you cannot start an IO, then we can give certain drugs down the tube. And the acronym for what drugs can be given down the tube is ever changing. Currently, it is Lean-V, Lean-V, and that's lidocaine, epinephrine, atropine, Narcan, and Versed. Lean-V. Those are the drugs that you can give down the tube. When we're giving drugs down the tube, we're going to double the dose and then flush with 5 mLs of saline, followed by 5 quick ventilations. So your patient has to be intubated. This doesn't work with a combi tube. It doesn't work with an iGel. It doesn't work with any other blind insertion airway device. The trachea has to be isolated. We have to have the patient intubated in order to give meds down the tube. So that means that if I'm giving epi 1 to 10, then I'm going to give 2 milligrams, which means 20 mLs of fluid, followed by 5 mLs of saline flush. So I'm giving 25 milliliters of fluid down the tube, and then followed by 5 quick breaths. Now, you just tell me, how effective does that seem? Probably not very, right? And after a dose or two of that, we're going to have other problems that we're going to have to start navigating besides just the fact they're in cardiac arrest, because now every time I push on their chest, stuff is bubbling up out of the tube. So medications in the ET tube are not routinely done. I strongly advise against it. I have done it. I've done it many times, but that was before we had IOs. Anyway, it is something you can think about. You do need to know the process for how to do it. Return spontaneous circulation, heart rate should be greater than 60. So that means that if I get ROSC and I still got this funky, wide, bizarre, really wide complex, and I think that it's probably ventricular in origin, and I have been treating a ventricular arrhythmia during the course of this code, then I may consider hanging an antiarrhythmic agent. Maybe I'll give 150 milligrams of amiodarone over 10 minutes. And that would be a good idea if the patient's heart rate was 182 with that wide, funky, bizarre rhythm. If the heart rate was 46 and still had that wide, funky, bizarre rhythm with no discernible P wave, then giving amiodarone is probably not the best option. That concludes cardiac arrest management.